much, and good morning or good afternoon to everyone. So I'm going to change it up a little bit and describe a project that we're doing here in Zambia. Although it says I work for the London School, I'm actually based full-time in Zambia. And we are conducting a project under the Stop TB Reach program called Ubumi Bwandi, which is all about how we can integrate screening and prevention with screening for TB. Next slide, please. So I know many on the call are experts in TB, but I just wanted to really bring out a few of the key issues from last year's global TB report from the WHO. 8.2 million people were diagnosed with TB in 2023, and that's the highest number ever. And while deaths are falling, incidence has increased. TB has once again taken the top spot as the most important infectious cause of death worldwide, and we're really not on track to end TB. And so we really need to think harder about how we screen TB, how we prevent TB, and particularly in high burden settings, such as South Africa we've been hearing about, but also in Zambia. Next slide, please. So Zambia is one of the 30 high burden countries worldwide, and our TB incidence nationally is 307 per 100,000 population. Zambia also has a very high incidence of non-communicable diseases. And TB, along with HIV and malaria, has had more external resources poured into it, whereas actually for non-communicable diseases, these resources have been less. And so services, consequently, have been more challenging to provide. I also think that in most lower middle income countries, places similar to Zambia, our health services are pretty overburdened, and they've been focusing on diagnosing and treating the sickest patients and really don't have an awful lot of time for screening and prevention of all these other diseases in their populations. We've heard a lot about screening and screening guidelines, and there are many diseases for which timely screening can provide a chance for early diagnosis and treatment. So we set out to try to integrate screening and prevention services for TB and non-communicable diseases in this project. So next slide, please. Just to give you a little bit of background, we did this project in one community called Chipulukusu, which is in Ndola on Zambia's copper belt, which is one of our mining regions. And it was a population of about 50,000, a population where I've been working for over 20 years, and in that time I've done 2 TB prevalence surveys and noted that the prevalence of TB was really high and not declining. So felt we really needed to try and do something to see if we could reduce the prevalence of TB. So next slide, please. I apologize that this is quite busy, but it's trying to show you all the different services that we integrate. First of all, we wanted to bring screening close to where people live, and recognizing that there is one health facility, government health facility in this community, but it's already very busy dealing with people who are sick. We decided that for wellness screening in people who are currently well, we needed to set something up in the community. So we developed something called a community hub, and I'll show you a bit more about that in the next slide. But in that community hub, we invite the whole community to come through, with our aim being to offer screening to everybody, at least annually. So that includes an annual chest X-ray, but also to provide other screening. So for HIV, sexual reproductive health, substance abuse, provide nutritional support, obviously TB screening, screening for other non-communicable diseases, such as measuring blood pressure, for screening for diabetes, providing information on common cancers, breast, cervical and prostate cancers and testicular cancer, and cervical cancer screening, and also provide healthy living education. We refer any individuals with conditions that need further management to the healthcare facility. And in the facility, they also do a similar screen to what is going on in the community hub. Next slide, please. So what did we do in the last year of this project? First of all, we developed this community hub. Actually, this is a building that belongs to the local council. It was a very derelict abattoir. You can see in the top picture, the image on the left, half its roof was missing, it was leaking, it was very run down. So we renovated that to become a community centre where a lot of other activities can take place, including community gardening, sports, various clubs, but also to be this community screening centre. We set up a chest x-ray machine with the help of Delft, both at the clinic, and that's the picture at the bottom. You can see the x-ray machine in the clinic is in a containerized setting. It's got solar panels on the roof. And also we have one of the portable chest x-rays at the hub. Everybody who comes through, we've given everybody in the community a card called an Ubumi Bwandi card, and it's like a loyalty scheme like you would have in a shop. So every screening or preventive activity you take part in, you can earn points, and you can then redeem these points when you earn enough of them for a reward. Next slide, please. We also had to employ some additional staff, particularly radiographers who didn't exist before because none of our primary health clinics in this region had a chest x-ray before. All the laboratory support was through the laboratory at the health facility. And we also did some outreach activities in other parts of the community, and you can see a portable x-ray being used here. We also partnered with many other organisations providing services such as mental health support and also eye screening camps, which were incredibly popular. Next slide, please. And just to give you a little snapshot of the services, the total number of adults that we enumerated in this population was just under 40,000, and about a quarter of them voluntarily passed through the hub or the clinic in the period that we were operating. And most of them had a chest x-ray screening for TB. And just to show you a bit more data on the next slide, again, it just really shows how many people, sorry, that hasn't really projected very well because there's quite a bit that comes off the bottom. Don't know why that's happened. But anyway, just to show that most people were screened with a chest x-ray, a proportion had an HIV test, and most people had a blood pressure check. Next slide, please. So our TB screen consisted of asking people about symptoms or having a CAD score of more than 50. And by doing this, we increased the number of people diagnosed with bacteriologically confirmed TB in this community. And we had a comparison clinic nearby, so we could also compare over time and compare with a comparison clinic. And we've shown a statistically significant increase in the number of people diagnosed with TB. We also found that a large number of people started TB treatment without bacteriologically confirmed TB. And most of this was based on X-ray. And of course, we also recognized that there were no alternative algorithms for other lung diseases in place at the moment. And so I just show you this chest X-ray. This is a man who's 45. He's had a history of TB in 2018, and he came with a cough and some chest pain. He is a smoker. He's HIV negative. He works in sand mining, so he has multiple risk factors for lung disease, but his sputum was negative for TB. And so the question really for the clinic, they would like to put him on TB treatment because they say this X-ray is abnormal, but probably he's got a degree of post-TB lung disease. Next slide, please. And just to show this to you in numbers, again, I'm not going to go through all these numbers. This is a slide that we presented at the union meeting last year. But when we screened those almost 9,000 individuals, about 900 of them were recognized as people who had either symptoms or chest X-ray signs that could indicate TB. We managed to collect sputum on 644 of those, and ultimately 224 were diagnosed with tuberculosis. If you can click again, please. But that left 420 people who had either symptoms or chest X-ray changes who were not diagnosed as TB. So what did they have, and were they given any treatment? What happened to them? Next slide, please. So what we decided to do was to apply to TB Reach for the next wave, which is wave 11, with our project called Ubumi Bwandi Pantanshi, which means my health, my choice going further, to really focus on how we can integrate lung health screening into this model that we've already got. To look about better diagnosis for pneumonia, for post-TB lung disease, for chronic obstructive pulmonary disease, and also industrial lung disease. We also wanted to improve our services based on the lessons we'd learnt last year and work a bit harder on prevention of lung disease. We see a high proportion of smokers, and so we wanted to set up a smoking cessation program and also expand TB preventive therapy. We also received some additional money from Bristol Myers Squibb Foundation to start looking and giving information about lung cancer in this community. Next slide, please. So this is the same diagram I showed earlier, just a bit more colourful. And in this one, the areas in red are the new things that we're adding. So it's mostly around lung health screening, but also working with the occupational health services in Zambia. There's the Occupational Health Institute, who are mandated to do screening for miners, but to work with them to do more outreach for ex-miners, people in the informal sector, stone crushers, cement workers, and also to set up respiratory clinic, which didn't exist at all in this district, at the secondary care level, where we can also do further investigations and spirometry. Next slide, please. Just going to show you our proposed algorithm, which again starts the same way, where we would screen with symptoms and the CAD for TB. Those individuals who are positive on that screen have an expert test done, all of them, and also a point of care CRP test. For those people, I'm sure many of you know this, but this stands for C-reactive protein. It's quite a non-specific marker of infection, inflammation, but it can be very useful in diagnosing bacterial infection. And we can do it on a finger prick point of care. Obviously, those individuals who have a positive expert, we can refer them to the clinic immediately for TB treatment. But for those in whom the expert is negative, which is the majority, we are going to use the CRP result to do a further triage, so that if somebody has a high CRP, we can give them antibiotic therapy for presumed pneumonia and review them. For those who do not have a raised CRP, it's unlikely to be bacterial pneumonia. And in that population, we will do some lung health screening and also get occupational history and refer for spirometry and also further assessment and management. Next slide, please. So what are the opportunities for lung screening beyond TB and also beyond chest X-ray that we're going to try and put into this project? As I said before, we're working with the Occupational Health and Safety Institute, who are mandated to screen miners, but to explore with them the role of CAD for silicosis in Zambia. And so we just heard from Rodney about the situation in South Africa. We have lower rates of silicosis in Zambia, but we still have many miners and many people exposed to harmful dusts. We're also expanding to communities employed in the informal sector, informal mining, stone crushers and sand miners, alongside OSHI. We're establishing the respiratory clinic, where we're going to be doing conventional spirometry and thinking about whether there's other ways we can look at spirometry, and setting up a respiratory rehabilitation service for post-TB lung disease. At the teaching hospital, we do also have access to CT scans, although they are costly and there is limited availability because they frequently break down for anybody who's suspected of having lung cancer or complex patients where we feel we need better imaging. And we're also incorporating lung ultrasound, which Guido mentioned right at the beginning, as an alternative to chest X-ray in screening for lung disease. We're doing this at the community hub, really seeing whether we could use lung ultrasound in this way in places where there is no access to chest x-rays. Next slide, please. I think there's also opportunities for continuing medical education. We're very proud of our virtual chest x-ray meeting that we have every week, where the radiographers present the patients with high CAD scores. And we have respiratory physicians from all over the country, from the main teaching hospital, ID specialists such as myself. We have the clinic staff. We have people from the Occupational Health and Safety Institute who join, and we all discuss the x-rays and we all learn from each other. And I think also we're starting to see the benefit of having annual x-rays and repeated x-rays. So again, this is x-ray of a 40-year-old gentleman who came last year, and his x-ray was the one on the right, and you can see it looks pretty normal and the CAD score is 6, and he came back only a couple of weeks ago for his repeat annual x-ray, and you can see he's now got what looks like consolidation up in that right apical upper zone, and apical region has a CAD score of 85, and his expert was positive for TB. Next slide, please. So I just want to thank all of the funders, all the people at Zambart and in Indola, particularly the community who guided us in what they wanted to see being screened, and I look forward to any questions and discussion. Thank you very much.